Good morning, everyone. Now today we will be continuing our previous lecture of diuretics, and in diuretics we have talked about proximal convoluted tubule, the drug acting on proximal convoluted tubule, that is was the mannitol and acetazolamide. Then we talk about the thick ascending loop of Henle, where the drug was loop diuretics, that includes furosemide, torsemide, and ethylhyaluronic acid. Okay, now we come to the distal convoluted tubule and in short discuss the physiology and then the drug acting on it and the clinical use and side effect. Okay, now when we take the cell from your distal convoluted tubule, then you know that this is your distal convoluted tubule, this is the lumen where urine is passing, this is the distal convoluted tubule cell, and this is the interstitial blood. In the distal convoluted tubule there is the basolateral membrane, and this is the luminal membrane. On the basolateral membrane there is a sodium potassium pump. Sodium is pumped out. Since sodium is pumped out, now sodium needs to be coming. Sodium needs to come in from the luminal cell, that is sodium chloride co-transport, or from your calcium sodium exchanger, the sodium comes in. Okay, this is the normal phenomena. When urine passes, sodium and chloride of your urine get absorbed into the cell and then finally goes into the interstitial blood. There is another channel called calcium channel that is independent of this your sodium chloride channel. So despite anything happens to this channel, calcium will be absorbed. Rather, calcium absorption is dependent upon the calcium and sodium exchanger. So if the sodium comes in and more, the calcium will goes out more. Okay, so in the presence of parathyroid hormone, if you are not using diuretics and in the presence of parathyroid hormone, okay, when we use the parathyroid, this exchanger activity increases. That means that calcium is pumped out more, sodium comes in. So since calcium is pumped out more from the cell into the blood, now there will be lack of calcium, and that calcium that drives this calcium channel to act more, and more calcium is absorbed. So you remember the parathyroid hormone, the main function was to absorb the calcium and vitamin D from the intestine. Okay, calcium and phosphate with the help of vitamin D from intestine, and when this was absorption, but when the come of reabsorption, then goes to the kidney, it only helps to absorb the calcium, whereas excrete the phosphate. So main aim was in the body is to increase the calcium level. Now coming to the point, the parathyroid understood, so the activity of the calcium and sodium exchanger will be more and calcium will be absorbed more. Now comes to the thiazide group of diuretics. When thiazide group of diuretics will be given, then this pump will not work. If this pump will not work, what will happen? The sodium is pumped out, potassium comes in. Now since lack of the sodium, so the sodium needs to come out from now interstitial blood. Since there will be more sodium need to come from interstitial blood, more calcium will be exchanged from the cell into the interstitial blood. That means that the calcium needs to be get absorbed more and more. Okay, more and more. So even thiazide diuretics, by inhibiting the sodium chloride pump, they actually indirectly increase the calcium absorption from your urine. So this is very important, because if a patient is having calcium stone and now this calcium is getting absorbed from urine into the blood, they will not get deposited. If you are not absorbing, this will get and deposited over here, and the stone will get bigger and bigger. Even more chance of stone formation will occur. So any person with renal stone or increased chance of renal stone formation, you need to give the thiazide group of diuretics. That you need to understand. The other thing that you need to understand is the sodium chloride pump. It inhibits it, so there will be the loss of sodium and chloride, and that will lead to what? That will lead to diuresis as well. Okay, so this was the mechanism. Now let's come to our main topic. Let's read the what is present over here in your. This is from your first aid. Okay, so thiazide group of diuretic thiazide, we have hydrochlorothiazide, chlorothalidone, then metazolone, metalazone, and indapamide. These are the drugs that are groups they belongs to the thiazide groups of diuretics. The mechanism of action is they inhibit the NaCl reabsorption from the early part of the distal convoluted tubule, therefore decreasing the diuretic capacity of the nephron, and also decrease calcium excretion. So decrease calcium excretion, so there will be more reabsorption if you are using higher groups of diuretics. Okay, Clinical use: hypertension, heart failure, idiopathic hypercalciuria. If calcium is lost in the more in the urine, you can give thiazide and absorb the calcium. And diuresis can be maintained and help in hypertension and heart failure. Then there will be a nephrogenic diabetes insipidus and osteoporosis. You may say nephrogenic there. When we were also the medical student, we used to get confused that why in nephrogenic diabetes insipidus, since there is a diabetes insipidus and more water is lost, why you are giving diuretics. Actually, it is a good trick to fool the body. What happened? Normally, your kidney is lost a lot of water, but when we give the thiazide group of diuretics, they act on the distal convoluted tubule and increase the diuresis. Since there is an increase in diuresis from the distal convoluted tubule, body gets the signal that okay, now in diabetes insipidus there is a lot of loss, but they are not checking it because it was nephrogenic, the problem of ADH receptor. Okay, now since there is a problem that thiazide group of diuretics, there is a loss of water. Now the body sensitizes, okay, we are losing the water. And since thiazide group of diuretic increase diuresis from distal convoluted tubule, now what happened? Now body, normally the nephron in the early part of your proximal convoluted tubule, it gets sensitized and it absorbs a lot of water over there, thinking that there is a loss due to thiazide diuretics. It seems to be a little confusing, but it is a simple mechanism. If you forget the term chronic diabetes insipidus, say just it is a condition. Now you give a thiazide group of diuretics. This will increase the diuresis. If there is increase in diuresis, body will think that okay, we are losing a lot of water, and because of that, the proximal convoluted tubule will try to conserve the water. And this is the feedback. And in utilizing this feedback, actually we are reabsorbing more and more water. So in fact, diabetes insipidus, normal nephrogenic diabetes insipidus, do respond to this thiazide groups of diuretics. So this is just a mechanism that can be applied, and it is actually applied in our body. So it is useful. If you not understanding, we will discuss more again later. But just to understand, although we know that there is a lot of water loss, the addition of this will say that there will be more water loss. But addition of it, what happened? The body loses the water more than the previous. But what happened when the body loses the water? Now this proximal part of the tubule gets sensitized, get feedback mechanism, and try to conserve the water, which was not doing in nephrogenic diabetes insipidus. Okay, now addition of thiazide has leads this proximal convoluted tubule to sensitize more and absorb more water. So now what happened? In combination of both of this, the proximal convoluted tubule will get activated and more water has been absorbed. So it is your symptoms get resolved. Your water loss get less in case of nephrogenic diabetes insipidus. Now also talking about osteoporosis, calcium is lost in the urine. Thiazide group of diuretics will help the calcium to retain in your blood or more absorption. So it will even help in osteoporosis. Okay. Now coming to the adverse effect. Adverse effect are high yield. Clinical use and mechanism of action is you have to know must. Okay. Then clinical use also you have to know must. But the more high yield becomes your side effect as well. Okay. So we are talking about hypokalemic. What are the side effects? Hypokalemic metabolic alkalosis, hyponatremia, sodium will loss. Okay. There will be hypokalemia as well. Then there will be a fourth thing like hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. Calcium absorbed, hypercalcemia, hyperuricemia, hyperlipidemia, and hyperglycemia. So you have to remember hypergluc. This is a formula given in your first aid, GLUC. These are all are hyper. That is the glucose, lipid, uric acid, and calcium. So these are you need to you can remember from here hypergluc. And hyponatremia will be there, hypokalemia will be there, because when sodium is lost or that part of the tubule wants to absorb the potassium, and there will be hypokalemia as well. You have to understand one more thing, that even in the part of your loop diuretics and thiazide group of diuretics, these two diuretics will lead to the metabolic alkalosis. Why metabolic alkalosis will occur? Because since sodium is lost in the late part of your tubules, what happens? Sodium get absorbed in the presence of aldosterone and potassium gets excreted. Body can't lose much potassium, okay, because it can lead to arrhythmia and fatal complication. So what happens? After a certain point, it exchanges with the potassium, but when it finds it is now low in my body, the body itself sends it, then it say, okay, I will not send you the potassium, now I will send exchange with the hydrogen. So sodium get absorbed and hydrogen get excreted. Since hydrogen get excreted, what happened? Now hydrogen loss is metabolic alkalosis. So all in this loop diuretics as well as in thiazide group of diuretics, patient will develop metabolic alkalosis. Although if you talk about acetazolamide, we are losing bicarbonate, so here will be metabolic acidosis. But in thiazide and loop and thiazide group of diuretic, we will have metabolic alkalosis. And this is very high yield. This you need to understand which drug and what type of metabolic disorder will occur, and that will be a high yield for you. Okay. Then there is a indapamide that doesn't cause hyperlipidemia. If your patient has hyperlipidemic condition, then indapamide can be used. Okay, and also sulfur allergy, because these are the sulfur drug. I hope this is a very easy thing. Okay, you don't have to be stressed much. You need to understand the mechanism. You know that, you know the clinical uses. I have explained a little, and lot of side effect we can take out if you know the physiology. And some of things you need to remember. So we have made a formula hyperglue, and that can be done. Okay, so now we'll later discuss on the next lecture about the collecting drug and the drug acting on it. Okay, thank you.